We're at AIDS 2018. We're here with Lewis, who is an immunologist from Oxford University. And you're a CIPHER grant awardee. And we wanted to get you an opportunity to kind of talk a little bit about your organization. But before you do that, give us your complete affiliation and title and so forth.
Yes, thank you for having me. My name is Louis Marie Yindom. I'm from the Nuffield Department of Medicine at the University of Oxford. So that's where I'm based, and I do studies in immunology as well as genetics. So I'm a postdoctoral researcher at the University of Oxford.
And tell us about the project you're on, which of course got you, I mean, this is a very large group of people. They select the CIPHER awardees.
Yeah.
You know, so you did very, very good work, apparently.
Apparently,
So,
yeah.
Describe what you're doing.
So my project was to look at chronic lung disease. So this is one of the complications that children develop from having HIV for a long time. So I was looking at chronic lung disease in children born to HIV-infected mothers from birth. And these are children that have survived HIV for a long time, above minimum of 5 years. So we recruit from 5 to 16 years. And these are, you can say, a selected group of kids that have managed to survive infection in those days without antiretroviral therapy. So most of them now, the aim was to get them and put them on treatment. And by the time when we got them, they were not HIV, they were still HIV treatment naive. But we put them on treatment, and after some time, we started looking at what happened during treatment. And we saw that some of the children were not having, their outcome from disease was not better. And they were having something called chronic lung disease. Originally, chronic lung disease will go away if you put kids on treatment, or people with lung disease, when they start antiretroviral therapy, they do well. But for some reason, these kids were not doing better. And they were being treated with all sorts of combinations, including TB treatment. And their TB treatment was not doing anything, was not getting them better anyhow, because they were not having TB. So we started investigating what are they having. And in the end, we realized, our colleague in Zimbabwe realized that they were having a sort of chronic lung disease that is not often seen in children.
Kind of, I'm hearing some things that I'm disturbed about. You have children that are 5 years old who knew they were positive, or older, that knew they were positive?
That didn't know, really.
Oh, didn't know,
because,
okay.
Because most of them didn't know.
So they were born with HIV probably went positive shortly after birth.
Yes.
And it went unknown.
Yes.
And this is in low-income countries.
This is low-income country. This is our cohort is based in Harare in Zimbabwe.
But you discovered they were positive through opportunistic infections of sorts, or in fact.
So our main collaborator in Zimbabwe is Professor Rashida Ferran. She has been working there for several years now, decades. And during her clinical service, she realized that some of these children coming forward were being diagnosed for the first time with HIV. And they didn't know they were having HIV, but because they are increasingly getting tired at school, they are not doing well, so it then became an issue, and the school kind of referred them to say, okay, go and check yourself in the hospital and see. And this is when they now realized they were having HIV. And when you look back to check, well, there is a large group of clinical investigators that are looking after these kids, and they then realized that there is a number of them out there. So they specifically set up a child clinic to encourage kids to come forward. And then it was then realized that many of them are out there not knowing they have HIV and probably developing some complications, even though they were doing relatively well physically. But they were
living with HIV untreated.
Untreated.
between the ages of, well, earlier, but you're looking at 5 to
5 to 16 years. On average, our cohort is about 11 years old, and you saw median age is about 11 years. So you see kids with for more than a decade without treatment.
Wow.
And this was before. I have to stress this is before antiretroviral therapy became widely available. So in 2015, it's now the test and treat. So everybody has moved on to
But if they have, they are being treated now, they're still, even though they're being treated, still, even though they go to presumably undetectable, they still have this chronic lung disease. Can you describe the chronic lung disease? Is it manifests itself as TB or?
Exactly, yeah. The chronic lung disease, this kind, what we are calling HIV-associated chronic lung disease, is something that looks like TB. The children will be coughing. They will have probably almost all the symptoms of TB, except that when you look out for TB by culture or by molecular techniques, you don't see them.
Yeah, that's interesting. So what you're seeing is likely going to be replicated a lot of places.
Definitely.
This is just a look at a very specific population.
We know this has already been, we have colleagues in Malawi that have looked at it as well, and they are finding this exactly the same thing. So there are about 2 publications now describing this scenario that hasn't been seen in the West or even in other parts of of Africa.
What percentage do you know what about?
This is a third of the children we are talking about.
A third of the children?
Yeah.
Wow.
So it's about 30% of kids coming up with this.
So your treatment is antibiotics? Is it bacterial? Or?
At the moment, there is no specific treatment for chronic lung disease with this type of chronic lung disease. That's why we have interest in it. That's why we want to see exactly what we should offer to clinicians to be able to assist them, diagnose these children early enough, and put them on some management therapy.
This is another further example of why we need to test and treat
immediately.
Immediately, yes. And so it's good to know this, but it's tragic to know that this is a challenge that is really not resolvable at this point.
Yeah. Unfortunately. So we went ahead to just to describe, to get a good picture of the condition. So we only selected for our study, for the study that I'm doing, we only selected kids that have been on antiretroviral therapy, and we know they are stable on antiretroviral therapy. This is to show somehow a proof of principle that ART is not definitely curing this disease. So on average, these kids have been on therapy for more than 2 years. They are responding to antiretroviral therapy, but when we analyze them, we still see that they have in these underlying factors, that is an underlying factor of chronic lung disease. So they are doing worse than other children that don't have chronic lung disease, although on treatment, and treatment is doing a fantastic job on them. So it's helping them picking up weight, behaving like other children, but not really resolving the issue of chronic lung disease.
Well, it's good to hear that you've identified this, and I'm grateful that you're getting the award to move forward on it and see what you can do about it, because it's very concerning.
Yeah, definitely it is. So I must say that my award, I was awarded in 2016. So I have already done a substantial amount of work on this, and we have now written a manuscript that will be published. And we are we had 2 aims in this work. One was to detect or find out if there are any biomarkers in the plasma of children or adults, or anyone that we can use plasma biomarkers of, because we know immune activation is one of the drivers of HIV. It's one of the things that is not good when you have HIV. So we are looking for markers of immune activation and inflammation, because we know following several examinations and many clinicians and other scientists getting involved, we know now that these children have problems with the lower part of their lungs, the small part of the lung, the bronchioles.
That's the part when you breathe really deep.
When you breathe really deep,
yeah.
and this we are suspecting, we hypothesize that there is a generalized inflammation on that lower part of the lung that is making them not to feel well, and so we want to see if there are any markers that we can use to pick up these children early in life, early enough to be able to say, okay, these are signs that this particular child will not do well on treatment, or we should put this child, in addition to the treatment they are receiving, we should give them something else to help them manage their condition. So we take blood, and then we collect plasma from the blood. We use a very sensitive technique called Luminex assay. These techniques can help you detect about 100 markers using a small volume of plasma at the same time. So we then design a panel of about 30-something markers of immune activation. From literature, you can know these markers are associated with inflammation or immune activation. So, and because it was the first time, nobody has ever done this in these kids, we had to widely test how many markers, several markers, so that we can then pinpoint those markers that will be giving us a sign, the first sign that these children will probably develop chronic lung disease along the line. So in total, we had about 213 children in our cohort, and 101 of them are HIV negative, and 112 HIV positive. And amongst the positive, we have two groups. A group of HIV positive without CLD, without chronic lung disease, and a group of HIV positive with chronic lung disease. So we now did our experiment testing all these markers on all these kids at the same time. So and we used 2 time points. So we picked the sample at baselines, time of recruitment, and these are, as I said earlier, baseline sample. Excuse me. Baseline samples are collected when the kids are already on antiretroviral and they are stable. So these kids are stable on antiretroviral for at least 2 years. And we pick the sample at time 0 and wait for 18 months and pick another sample.
And you see for correlations?
We want to check if a marker is increasing or decreasing, and if it is still linked with chronic lung disease. And we have statisticians helping us to model the things to see, and already we are seeing signs that certain markers are associated with chronic lung disease, and that is if you compare the group with chronic lung disease with the group without chronic lung disease, and over time you can see certain markers are increasing and some markers are decreasing, and some of these markers can be linked directly to some pathways that we know are associated.
There's enough population in the study to answer the question?
There is, yes.
Yeah.
Yes.
Well, I'm looking forward to the answer, and I'm looking forward to the manuscript.
We hope so, yeah. We hope we will get something more cheerful to people to help this kid, to help the clinician identify this kid early enough to be able to put them on treatment.
Great.
Another thing we were looking at, as I said, we had 2 aims. One was looking at biomarkers. The second one was looking at CMV. Right. Because we know CMV is something that drives immune activation. So we know CMV in Africa, about nearly 100% of children get infected with CMV by the age of 18. So given that these children were infected from birth or soon after birth, they must have also acquired CMV along the same time. Right. And this is acquiring CMV at a time when your immune system is not properly mature. And so we wanted to see, is there frequent reactivation in this kit that is driving the immune activation and exposing these children to other complications? Right. And yes, we can say yes. This second aim has also been done. Now we can, excuse me, we can clearly see that children with CLD, CLD, chronic lung disease, have a 10-fold higher both HIV viral load and CMV viral load compared to children that do not have CLD. So this is a worrying situation. Yeah. And I think the next step would be to probably try to also resolve the CMV reactivation in these kids that are on treatment. So even though they are on treatment, CMV keep coming up and down, keep coming up. Under normal circumstances, after 2 years, the children should not have CMV in blood. They can secrete it in other compartments.
It
but
will
they
still be
shouldn't.
there, but
it will
it
still be
won't-
there,
yeah,
but
but it's
it
not
will be
being-
dormant. It wouldn't.
PBMCs will be gone.
Yeah, they won't resurface until you have some issues that will compromise your immune
Right,
system.
and your immune system drops, right?
Yeah.
Well, thank you very much for your,
Thank you very
your
much for
time, and I
having me.
appreciate you explaining this to us. It's very interesting.
Thank you.
I look forward to the results.
I hope the result will be what you are expecting.
And you too.
Thank
Yeah.
you.